Aha, there we are.
All right. Okay, let's get started. Good morning, everyone. I, along with Dr. Ehrenfeld, who we both invited Dr. Schonberger here for this virtual visiting professor lecture this morning. I have the great pleasure of introducing Dr. Robert Schonberger from Yale University. Just a little bit of a background. Dr. Schonberger received his bachelor's degree, a master's degree, and his MD from Yale University. He completed his cardiac anesthesia fellowship also at Yale in 2012 before joining them as a faculty, where he's now currently an associate professor. Dr. Schonberger is very passionate about training the next generation of academic anesthesiologists, whether he thinks that or not, but there's a lot of proof on his CV. This is evidenced by all these titles that he has. Then Rob, I didn't know you had this many titles, but I'm going to read them off. He's currently the director of the clinical scientist track. He's the director of the research scholars program. He's the director of the trainee academic development. And he also runs their currently funded NIH T32 training grant. As you'll hear today, I'm not going to steal your thunder, Rob, but Dr. Schonberger believes anesthesiologists can improve care not just in the perioperative period, but we can extend this into improving overall population health, something that I've always thought was very fascinating that he works on. His work has led to originally a FAIR MRTG, which is a mentor training research grant. He then made the jump to the NIH, where he was funded by a K23 award through the NHLBI. And then he made the impressive jump because, side note, only about 33% of people who hold K awards go on to receive an R01. He received his R01 through the National Institute of Aging, which he currently holds. So in my eyes, Dr. Schonberger is a true academic, and he's actually still learning. He's currently earning his, I had to look this one up, Rob, his MHCDS, which is his master's in healthcare delivery science. So we look forward to hearing what you have to say about MPOG and Aspire. And thanks for joining us.
Thank you, Julie. Can you hear me?
Yes.
Yay. Okay, I'm not muted. Thank you so much for the invitation. I'm just going to jump right in. That was a very lovely introduction. It's an honor to join you guys at MCW this morning. And when Julie extended the invitation to me, I just felt totally touched. Medical College of Wisconsin's always been held out by my mentors, specifically Laura Nicholson, as a program toward which we should aim in our own attempts at promoting academic anesthesiology. And I have to share a quick story. When Dr. Fried came to speak at Yale a few years ago, Dr. Nicholson sat with our chair, Roberta Hines, for several hours over the course of a couple of weeks. And they invited me to one of their strategy sessions. And the one I was witnessing was their effort to try to figure out how they might steal Dr. Fried from Medical College of Wisconsin. And that meeting ended when Laura had looked extensively into MCW, and she threw up her hands and she suggested to Roberta, you know, it's just going to be much easier and more efficient if Schonberger and I pack up our stuff and move to Wisconsin instead. And Roberta said, okay, fine, I give up. So again, thank you for having me. And I'm going to talk with you guys this morning a bit about the Multi-Center Perioperative Outcomes Group, MPOG, which I understand you guys have recently joined. What we've been doing with MPOG Aspire at Yale in terms of QI and research. And I've entitled my talk, First Do No Harm, Repeat as Needed. And I chose this title because in the world of quality improvement, as many of you know, especially when you're using electronic health records to try to generate that quality improvement, it's critical to approach it with humility and to acknowledge up front that this kind of QI can get dangerous, and it's filled with not so fun stories of unintended consequences. So that's the overall title. Before I get started, I have a conflict that Yale requires me to disclose. I hold an equity stake in Johnson & Johnson. Nothing I say should have anything relevant to that conflict so far as I could possibly tell. So now that that's disclosed, I'd love to get started. Agenda for today, Dr. Fried asked me to talk about myself. I'm not so skilled at talking about myself, but I'll do my best to tell you. I got an unstable view. Can you guys hear me still? Are we good? Okay, I think we're good. Okay, my connection said it was unstable. I can call as a backup if I need to. So I'm going to talk a little bit about myself, show a few slides about my career path, talk an overview about MPOG and Aspire, talk about data quality and Yale's focus on a few of our quality metrics and some future directions. So I'm going to just jump right in. The me slides, I'm going to skip a few of them. I'm not that good at talking about myself, but I'll tell you this. When I was a resident in 2008, as many of you have had the experience of, I cared for a patient with a deadly treatable and undiagnosed disease, ambulatory operating rooms. I'm sure you all have this experience all of the time. You have a patient with elevated blood pressure. Many of your patients are not on antihypertensives. I went to Paul Barish, my mentor, who's pictured here at the left. He passed away this past year, unfortunately, much to my sadness. And I went to him and asked him a simple question: what's the relationship between preoperative and primary care blood pressures? Because I found that my somewhat impatient attendings kind of found it annoying when I would delay our cases because I was discussing the last patient's essential hypertension. Dr. Barish came to me and said, go look it up, Schonberger. And I told him I had, and I didn't see much in PubMed. He replied, what can somebody, please teach Schonberger how to search PubMed? It just seems like such a low-hanging fruit, obvious question. But it turned out I was right. There was almost nothing published on this very simple question. And when Dr. Barish himself did his search and saw this, he came back with a twinkle in his eye and he told me to pursue this area further. It seemed like an interesting question, quote, for a resident. At that time, I was fortunate enough that Dr. Nicholson, 2009, had just gotten our departmental T32 research training grant at Yale. And she thought maybe it wasn't just interesting for a resident, but that I should come onto the T32 and start looking at population health in the perioperative encounter. And so I did that, the T32, and ended up getting a K award from NHLBI, where we further pursued these kinds of questions about population health. And as part of a K grant, as some of you are likely to know, there's a career development component. I pursued training in clinical informatics, and that ended up being a piece of my training that kind of has carried through till today and is relevant to the work I'm going to talk to you about MPOG, and kind of enabled that whole thing. And so before I move on to MPOG, I will just tell you that my K grant resulted in a not quite Nobel Prize winning discovery that in fact blood pressure does predict blood pressure. This was my great K award finding, and I'll just tell you, we sent about 100 patients at one point home from our pre-op clinic prior to surgery with home blood pressure monitors. And we confirmed that if your patients show up with a systolic of 160 or more, you can be darn sure with 95% certainty that your patients are not just anxious, but they may be nervous and also hypertensive. Again, with 95% certainty, someone who's 160 in your clinic is also hypertensive at home. After the K grant, I'm kind of trying my best to do a K dismount with minimal blood loss, and was able to get, oh, I'm going the wrong way here. Let's see here. There we are. Sorry, guys. We'll get the Zoom / PowerPoint worked out. I was able to get an R01 recently, and kind of still in this post-K land of R01s that I was just chatting with Dr. Fried about, and still trying to figure out if I'm going to succeed. On the bottom left here, I have just one more graph before we get into the major topic of this around MPOG. This is actually MPOG data, so it fits in on the bottom left here. The horizontal lines here are patients of increasing age, the top one being 65 to 70, then 75, 70 to 75, 75 to 80, and the bottom line is patients over 80. The vertical line from left to right is ASA physical status 1, 2, 3, and 4. And each of these boxes represent tens of thousands of patients from the MPOG consortium in regard to how much propofol bolus dosing they received at induction. You can see the vertical lines in each of these histograms, and those vertical lines represent what the FDA guidance says is the maximum typically required induction dose for people of that age. And you can see that for every category, except for the bottom right, sickest and oldest patients, what we give our patients, the modal dose of what we give our patients, the most common dose, is at or meets or exceeds what the FDA considers our maximum expected propofol induction dose. So this is something we just published actually a couple of weeks ago from our grant-supported work. I should hasten to ask, it is totally not clear whether the anesthesiologists are wrong or whether the FDA is wrong. We don't know that, and that's what our R01 is designed to try to figure out. But based on our data, it is certainly true that we can't both be right. Either the FDA or modern anesthesia practice is off, and the R01 we're working on now is trying to figure that out. And again, it's from the clinical informatics stuff and MPOG combined. So that's a brief history of me. And now I want to move on to MPOG Aspire, what they are, discussion of data quality, and what it might be used for at MCW, what we've used it for at Yale. This is a map on the bottom here of MPOG sites. You'll notice that, once a state has an MPOG contributing center, they fill it all up in blue, which is a nice creative interpretation. And I see that Wisconsin will soon be adding to the sea of blue. And that's very exciting for everyone in MPOG, because when you're added, every researcher across the country benefits from that. So thank you. On the upper left here is a kind of a summary of data flow in EPIC centers. And it just kind of a schematic here. The gray over here, these are kind of your pre-existing Chronicles and Clarity servers that make your EPIC system kind of work. That's where your data are. The green things are servers and data sets that would be added as a result of your MPOG participation. And then you go through a process of cleaning your data, removing identifiers, collating things in various ways, and then submitting them to MPOG. And then the MPOG central database is available for researchers around the country and indeed in Europe as well. So that's kind of the overview. Now that's kind of the EPIC thing. This has come about with modest blood loss as a result of some prior versions of the EPIC MPOG transition. We were the first site to go from EPIC to MPOG, and it was not thanks to me that happened, but our CIO was involved and got it done. But this is now a pretty well-traveled path and shouldn't be that much blood loss for you guys. So hopefully you've gotten through this and you're now joining. And this will enable you to also join the Aspire program. In 2016, we joined Aspire. And this is part of the MPOG quality improvement arm that involves sending monthly emails to our attendings. And so now, actually not just our attendings, to our residents and CRNAs as well. We now send about 300 emails out to participating providers each month. Don't worry, it's not 300 emails to each person, but just one to each provider. There's an example here on the right of what an MPOG Aspire email looks like. This one says, "Hello, Robert." It includes information regarding how Robert did on several of the process of care and outcome metrics that we track. It shows how I did and how all the other attendings in my institution did. And we can look at those and kind of do personal QI and feel either good or bad about ourselves in relation to our neighbors. I want to talk a bit about that and the necessary risk adjustment you should be doing internally, even if it's not provided in the email for you. And by the way, your site can choose which ones of these metrics show up on your local emails. Now, before you get that email, you'll also get a registration email. Why should you not just put this in your junk box, even if you're not so interested in informatics, QI, and research? If you do register for this, it helps you be able to access your data. You can participate in personal and departmental QI. You can also improve data quality overall, because if you spot errors in your data, there's probably a good chance other people have a similar mapping error or whatever. And so there's an iterative process. And when you complain to your local site PI, whoever you are, I'm sorry, local site PI, you should definitely complain to your local site PI. They can fix things and then iteratively improve stuff. And not only does that improve stuff for you, but again, the whole consortium benefits the more MCW's data reflects reality. The last reason, and often actually the most important one for many of our attendings that folks register, is that the ABA offers MOCA Part 4 credit. Part 4 credit is done prospectively. So when you join, you have to follow your Aspire metrics for at least 12 months. And then only after that prospective following do you qualify for the 25 points of MOCA Part 4 credit. So if you decide not to join with your registration email and then you come later to your MPOG site PI, it's going to be a delay of 12 months subsequent to that before you can get your MOCA credit. So that's why you might want to join and register. So what are the things that we actually report these days? There are a bunch of process of care metrics. We look at train of 4 monitoring. And when I say we, I mean the consortium as a whole, neuromuscular reversal administration, low MAP prevention. Did you have MAP less than 55 for at least 20 minutes during your cases? Did you have monitoring gaps? Were there gaps with more than 10 minutes without a blood pressure? How were your tidal volumes during mechanical ventilation? There's a metric which looks at whether your median tidal volume was less than 10 cc's per kilo of ideal body weight. Look at Narcan and flumazenil administration as indicators of potential overdose. Look at colloid use, which is in accordance with the Choosing Wisely campaign of the ASA. There's some transfusion management things that we'll look at today in my talk, hyperglycemia treatment, warming and temperature monitoring. And there's a new metric, a mean fresh gas flow measurement designed to reduce anesthetic waste gas. And then there are a few outcome measures that are minimally risk adjusted. And those outcome metrics include postoperative MI based on measured troponin levels, postoperative AKI based on measured creatinine, normothermia, PONV, and a few others coming down the pike. So those are the things you can get. Which ones actually show up on your email is up to your local group. Folks often ask, well, if it's not well risk adjusted, what's the point? Here is just one example of what an acute kidney injury metric might look like within your email. This particular provider had a total of 9 cases that were not excluded from the acute kidney injury metric based on the length of the anesthetic and the person's particular procedure. For me, when I see this, I say, oh, you know, I had, and this actually was me. I had a patient with an AKI. I didn't realize I had that. Why would that matter? Well, because I care. And it's interesting. I wouldn't have known that this particular patient had an AKI. I click on this link in the email. It's a live link, and it takes me to the acute kidney injury metric slide, where I can see the inclusions and exclusions of the metric, how they define the responsible provider, who they've attributed the AKI to. And it actually will give me the failed cases over the last month. It has some PHI in there. It also, which I've blocked out, tells me that I had a mitral valve repair. It tells me which room I was in, gives me the pre-op creatinine of the patient, the post-op creatinine of the patient, the stage of acute kidney injury that I have incurred. It also tells me whether my patient also failed the metric looking at hypotension, MAP less than 55 for more than 20 minutes of the case. I can also click on this button, View Case, and the View Case button will click on an MPOG version of the abstracted case as it exists in their system. Now this is how come it says that X happened when in fact Y happened. There's a charting error, and you can go through and correct those. You can look at a variety of things: ventilator management, medication administration, fluids, labs, physiologic data, including blood pressures and things like that, and other free text events that you had. And you can look. And in this case, you know, I look at my patient who had her mitral valve and had a bump in her creatinine. And in this case, as is often the case with AKI, I didn't see any particular, you know, mistake, so to speak, or area that I might have improved, although it did generate some questions. It was more of a kind of an informational thing that, oh, you know, Mrs. Jones had an AKI and I wouldn't have known otherwise. And so I found that for a very useful thing, and I found that going on a very useful thing just to kind of keep track of some of my patients and what happens to them. So that's an overview of MPOG Aspire emails, what they look like. A big issue with all of this EHR stuff is what does the data quality look like and how do we ensure it? You know, what you don't want to have is the garbage in, garbage out phenomenon. And how do you ensure that, at least in your MPOG system, that that's not happening? There are, I'd say, 5 ways or so that one can look at data quality to ensure that what you're getting is reasonably associated with reality. The first two, the one at the top is that we get machine captured physiologic data. That is a double-edged sword. I know for many of you, you will be from the age that I am from when the first chunk of our training and the first chunk of our being and attending was done on paper charts. And we all remember, if we've been in those days, the regression to the mean that can happen in our blood pressure monitoring, the railroad tracks that tend to happen when in fact, it's not clear whether how many milligrams of epinephrine became a chartable event, depending on who your attending was as a trainee. They look at you and say, oh, that was hardly chartable. And of course, I'm exaggerating, but we all know that somewhere on that spectrum, there is a little bit of editorializing in that paper chart. So when you get machine captured vitals, if the blood pressure says 220 over 120, there's a decent chance the blood pressure was actually 220 over 120. It's going to be in there. Now, of course, occasionally it wasn't 220 over 120. And as a provider, you can always go back and chart that something was artifactual. Whether you actually take the time to do that is a question. But the blood pressure will read 220 over 120 for better or for worse. I would say, having been in the era of paper charting, overall, it's for the better. The second thing we do for these accuracy checks is a monthly random audit of at least 5 of the charts that come out of MCW need to be reviewed by hand by your site PI or their designee in the electronic health record, looking at, does the stuff we're sending to MPOG look like the stuff we have in our own Epic record? And there are check boxes. You're going through these things, at least 5 a month. And when you spot problems, it's not just, oh, yes, it looks kind of like this. Sometimes it doesn't. And you can go through, and the MPOG folks are absolute saints about helping you figure out what problems you might come across. So those are the first 2 major things that we do for data quality. The other things are including automated data quality assessment. I'll show you a little under the hood kind of view here. So you can look at your data relative to the other groups in the MPOG consortium and see how your data is doing. So on the left, we have the percent of all of our Yale New Haven cases that had an intubation note. There is clearly a long range of acceptable percentages based on your case mix. And I can see that our case mix is about where it probably should be in the consortium. And more importantly, there are no crazy jumps. It's not as though we suddenly lost half of our intubated patients one month. And that would, sometimes you do see that would indicate a data problem that you can then fix. On the right, percent of cases with an arterial line, again, you can see we're reasonably stable and we're doing well. And this kind of thing should happen at least every month, just to check that your data for that month is continuing to be where it should be, or if it's not, it's getting fixed. Here's an example where it wasn't where it needed to be. This was a fair amount of blood, sweat, and tears for me. This was Yale's percent of cases where there was a valid preoperative weight documented, going back way to 2014, and this goes up till about 2018. So this represents 4 years of Schonberger working really hard to make something better. You can see that not everything I do results in success. I managed to get our literally meeting with the QI folks, the informatics folks. I got our data up from about 69, 70% to about 73% after 4 years of work. The fortunate thing is that the new data model that MPOG uses with specific to Epic sites, this kind of problem is no longer happening. So our data now say 99, something like that, high 90s%, and we're in the green. But it's like one of these, you just can't fight City Hall. Sometimes there's a fundamental problem that you can't fight. But the good thing is we knew this was happening. So we could tell our providers, look, when you get weight normalized metrics, 25% of the time, it is garbage. So please ignore it. And at least it's stably garbage. It is what it is. You can at least tell people what it is. Here's another example of where bad data actually means good data. So this is our percent of patients receiving an anti-emetic. And back in 2018, I don't know if you guys remember, there was an ondansetron shortage. Ondansetron, at least for Yale New Haven, disappeared from our carts for a few months in 2018. Well, there you go. We saw that in our data. And had we not seen that, we would have started wondering, what's going on? How come we haven't seen this data? The fact that we see our data getting quote unquote bad means in fact our data was good. So that automated data quality assessment's another one. Another one that I would really encourage you guys to do, and I'm happy to talk offline with your MPOG site PI, is to do your own statistical analysis and kind of checking on how things should look. I just stole this slide. I took a picture of Avery Tung's slide. I don't feel too guilty about it because at least I'm giving him credit. Here's a picture of Avery Tung. He was presenting his data on AKI at University of Chicago. And you can see the spread of incidence of AKI across his attendings. You can also see that he labeled his attendings based on their subspecialty, and the cardiac folks are on the right, the pain and OB folks are on the left, and the mean is 3.4%, whatever that mean means. The moral of this story from Avery is if you want to look good, be careful who you choose to hang out with. Find a cardiac attending and stay near them. You will look good. Another moral of the story is if your data don't look like this, you have a data problem. And a final moral I will add is if you're one of those cardiac attendings or not, if you're the OB attending, don't compare yourself to how someone else is today, but how you were yesterday. So this is our Yale data. We put it up by a random sample of attendings, looking at AKI01, which looks at an increase of 1.5 times the baseline creatinine in the first 7 postoperative days, or when it increases 0.3 milligrams per deciliter in 48 hours after anesthesia end. And you can see our data look like Avery's. This is good. But then the question is, who are these attendings? Let me go forward here. I lost that. There we go. Okay, here we are. So these are our cardiac attendings in this random sample. Yay, I was so relieved to see this. We look like we should. Our OB and pain folks are on the right, some cardiac folks are on the left, and then there's this yellow guy over here. What is this yellow person? It turns out that's one of our liver transplant attendings. So everything looks okay. This was very heartwarming for me to see. Now, if your data don't like this, you have a data problem. Question: if you have comorbidity codes and you have demographic codes and you have procedural codes, why don't you just risk adjust? So we wanted to address the relationship between comorbidity codes in our MPOG data set and how close we get to mortality. So we did another analysis, just kind of an informal ICD-10 coded codes for Charleston Comorbidity Index, and looked at mortality after 1 year. These are our local data looking at the discrimination of our ICD-10 code generated Charleston Comorbidity Index and 1 year mortality. The area under the curve was 0.78, which actually is right there where the literature would say the Charleston Comorbidity Index should be. And so we felt pretty good about that. The message, bottom line, was our comorbidity and mortality coding compares favorably with expected Charleston Comorbidity Index performance, and we do pretty well. Well, okay, if our data are pretty well, let's apply that. Let's go back to our attendings. Here they are. Here are the red cardiac people and the yellow liver people. Let's follow them. If we can take the best risk adjustment model we can for acute kidney injury and see what happens to them. Well, here they are. These are the red cardiac attendings. They kind of filtered down, but unfortunately the green ones are also cardiac attendings who filtered up, and the blue ones are some more of our liver transplant folks. So, you can see that, risk adjustment has its limits. This is like those of you who may be doing today a thyroidectomy in a patient who's a smoker with a history of a reactive airway disease, and at the end of the case, the surgeon says, please don't let the patient buck. And you do your best, and you have your low dose Remi or your magic lidocaine or whatever your particular bespoke combination of drugs is to prevent bucking in your patients. The bottom line is there is no bucking dial on your machine. There is no risk adjustment dial on your MPOG data just to turn and have it happen. So people filter up, people filter down. You still basically, when you look at AKI, for example, you get a good sense of which section you're in more than how you're doing. And within a section, even within a section, you see the percent of the call that was taken by that person over the previous month. It's all about case mix. So you can't just simply risk adjust. Here's another story about risk adjustment. let's talk about the big guys who do this. So New England Journal, this was 2008, Massachusetts, state of Massachusetts took data from over 2.5 million hospital discharges covering the years 2004 to 2007. They gave these data to 4 teams. They were volunteer teams from Thomson Reuters, Premier, 3M, and Imperial College London. And they asked a single question to these 4 groups who were no wilting violets in the world of risk adjustment. The question was, do whatever you need to do, rank our hospitals. We want expected versus actual mortality. Let us know how we're doing. They did it. All right, well, what happened? Well, what happened is they got a New England Journal article out of it because in fiscal year 2006, 28 hospitals were designated as having higher than expected hospital-wide mortality by one of the 4 volunteer groups, and 12 of those hospitals were simultaneously classified as having lower than expected mortality by other methods. This wasn't just that some were higher than expected and some were average. They came to opposite conclusions for a decent percent of low performers. 43% of low performers by one method were high performers by another, not just average performers. So you can see risk adjustment is not a magic panacea. Okay, so that's a little bit about data quality. I'm going to go into some specific experience we've had with 3 of our quality metrics, and we're going to look at excessive tidal volumes, patient warming, and transfusion. Show you what we've seen at Yale, and it'll be potentially something useful for you guys to think about. So here you have back 2014, we joined this goes back to 2015. These are our data. The blue line is Yale. The orange line was everyone else in MPOG, and this is the percent of patients who were not ventilated at greater than 10 cc's per kilo. So higher is better here. You can see that we were kind of lagging along about 1 in 5 of our patients initially. And this is actually data that nobody knew they were tracking this. We didn't talk to our attending and say, hey, watch out, we're looking at tidal volumes. So this is kind of like going back in time saying, okay, we've now joined Aspire. Let's go back and see how we were doing. This is kind of the natural experiment of how our attendings were doing. And about 1 in 5 of our patients were getting greater than 10 cc's per kilo of ideal body weight during mechanical ventilation. Okay, it's good to know. We seem to be getting a little better. We joined Aspire, and you can see right here, actually, this jump from July to August of 2016 was the 2016 month when we started sending out Aspire emails. We weren't sure how it would work. Half of our attendings started getting these emails, and we saw an immediate jump. And we are pretty sure we had a lot of cases, and we do. So we're kind of like, and back then there were fewer MPOG cases. So I think the jump in MPOG that you can see in parallel is probably from Yale largely. We went up within 2 months. We were over the kind of predetermined success rate of 90% adherence, and then we flattened out. You can see in October of 2016, we came up with a clinical decision support tool, which alerted people when their patients were getting what we considered might be excessive tidal volumes. That popped up on their charts. And then the second half of our attendings started getting emails in November 2017. And you could see then that we were kind of right up there with all of our peers in terms of lung protective ventilation, or at least not over ventilation in terms of volume. How did we do since then? Well, I'll fast forward to 2019 and 2018. You can see we're the blue institution here. All the others are gray. We kind of maintained our change in practice. Whether this has done any good for postoperative pulmonary complications is not clear at all, but at least this process of care metric has been improved, if you think that that's an improvement. And then, of course, the biggest thing we did was actually just change the default setting on our ventilators, because about 70% of the time those default settings never get touched. Anyhow, that's one little story of quote unquote success in a process of care measure. How do we at least try to look like everybody else? I'll go to patient warming. Patient warming is an interesting one. There's plenty of good evidence. This is Andrea Kurtz and Dan Sessler's group, looking at a randomized trial of active warming to no active warming back in the pre-industrial age of 1996. And they found that patients randomized to no active warming had 4.9 times relative increase in the odds of postoperative infection. These, I believe, were colon, large bowel surgeries. The only stronger determinant for infection was active tobacco use. So this 1996 New England Journal, warming matters, at least according to them in a prospective randomized fashion. We have a metric called Tempo1, which looks at active warming. Did we document active warming from a convective or conductive heater? between anesthesia start and anesthesia end? This will be on your spiral emails. Or was your patient warm? Were they over 36 within 30 minutes before extubation? Either of those will count as success. As with many MPOG metrics, you will see that there are some very thoughtful exclusion criteria. MRI and radiology are out. Cases under 60 minutes are out. Non-operative obstetrics are out. For cesarean deliveries, a fluid warmer is accepted as an active warmer. I think people didn't want, bear huggers getting between mom and baby kind of thing. And then finally, the threshold is 90%. Everybody understands that anything that you're doing probably shouldn't happen 100% of the time, at least in the world of the electronic health record, with some exceptions. This is how we were doing all along, kind of trailing the national norm modestly in the later months. This is what you can also visualize, and you'll be able to do this, how we did relative to our peers institution-wise. Each one is an anonymized institution, but I'll tell you the secret of where we were. This was Yale over here. You can see the red line was considered success. So we were actually trying to give ourselves a trophy. I told everyone we were in first place among people who failed. We were, the best below the threshold. If you prefer, this is actually also quantitatively true. We were second place in the bottom 20%. So we got first place and second place. You just have to kind of reorient the bar you're trying to meet, and then you can have a trophy. This obviously wasn't where we wanted to be, and we've actually been working on improving our normothermia maintenance as an institution as one component of our SSI improvement efforts, which are really hard, as I'm sure you guys know. Here's Nancy Pelosi giving us her Donald Trump speech clap, which was, I guess, what I was doing to everybody, calling us second place among the bottom 20%. Here's a question for you, though. So if we want our attendings to care about this metric, we kind of want them to be convinced that it matters. So there's another metric called normothermia, called Tempo 3, which is actual normothermia. This is kind of the outcome measure. Was your patient warm? So Tempo 1, did you warm them? Tempo 3, were they warm? And we just did a simple McNamara's test here, trying to show people that the association between trying to warm them and them being warm, just as a straight kind of rough first approximation, p-value comes to 10 to the negative 156th, which I think even satisfies some of the more stringent p-value requirements that have been promoted in the literature. Patients who are warmed tend to be warm, at least in 2018 and 2019 at Yale, and probably the same in your institution. But it gets complicated. When you warm patients, are they warm? This is one of our lovely residents who's now going to be one of our T32 fellows, Clark Fisher. He had a FAIR poster in 2019. He did an analysis. He used a bunch of cases, the same cases from the prior slide, at one of our campuses for about a year. He looked at cases passing or failing the temperature active warming metric and core temperature measurement and postoperative normothermia. He looked at per resident success. Individual resident performance across the two process measures was correlated. If you both did one of the processes of warming, you also tended to do the other process of warming. Process measures tended to group in their success. However, there was no significant relationship between a resident performing well on the process measures and a resident performing well on the outcome measure. We found this fascinating because overall, when you don't divide by individual resident, you see a very strong association. When you dig down and you look within a resident, you don't necessarily see that they're doing better than another resident. So how do you figure out, how does that all fit together? I'd say one lesson would be that we would confirm temperature process of care is important for outcomes. However, your comparative performance with peers on the process measure does not guarantee that your comparative performance on the related outcome measure will also compare favorably because you have a confounder. Your confounder is case mix. More senior residents are doing sicker cases. Just because the more senior residents might be doing these process of care measures more than their more junior resident colleagues, they also have patients who might be harder to keep warm. And this pops up in all kinds of surprising ways in EHR quality metrics all the time. And every time we catch it, we think, oh yeah, we found it. And then when we don't catch it, probably half of the time when we haven't caught it, we just missed it. It may still be lurking there. There are confounders all over these data. This brings me to one of my favorite concepts called Simpson's paradox. If you want a really good version of Simpson's paradox, you can go to Harvard's introductory statistics class, which is free on YouTube, called Stats 110. Stats 110 has an amazing lecture on Simpson's paradox. Here's the question. A clinician, can they be more skilled at treating every subtype of case, but nevertheless appear to be less skilled overall? A parallel case is, I know opening day was recent in baseball. Can you have a batter who has a higher batting average in the first half of the season and in the second half of the season than player two, but actually end up with a lower batting average? And the answer is yes. And it all happens. Here's an example of how it can happen in the actual data. So this is actually made up data, but the principle is here. Let's say you have two anesthesiologists, Barish and Miller. They are doing toenail removals and open heart surgeries, and they have some metric of success that they're trying to do their best with. You can see that among toenail removals, Dr. Barish's success rate is 93% here using these numbers, and Dr. Miller's success is 87%. Dr. Barish seems to be better at toenail removals. When you look at open heart surgeries, Dr. Barish, again, has a success rate of 73%. Dr. Miller has a success rate of 69%. Dr. Barish seems to be better at open heart surgeries. Dr. Barish would be the preferred person to go to if A, you had a toenail removal, or if B, you had an open heart surgery. Add these things up. All the people you treat, you might say Dr. Barish actually ended up worse than Dr. Miller when you add these up. So these things can reverse. They happen in all kinds of interesting situations. Another one that you can play around with that's actually mentioned in the Harvard course, if you have two bowls of jelly beans, let's say you have, I don't know, green jelly beans and orange jelly beans, and you really like orange jelly beans. And there's a bowl in your workroom at work, which you know has a higher percentage of orange jelly beans, so you always go to that one than a second bowl. If you combine those two bowls, I'm sorry, if you have, I misspoke. You have 4 bowls of jelly beans in 2 different workrooms. The orange jelly beans in the first workroom are in bowl A, and the orange jelly beans are more commonly in bowl C in the second workroom. One day you come and all 4 bowls have been actually combined into two separate bowls in a single workroom. It turns out which bowl is preferable may switch, even though both workrooms had bowl A being the preferable one. This is Simpson's paradox. It shows up all over the place. The bottom line is you have a latent variable, a confounder, which is case mix. And you can't forget case mix when you're looking at how you're doing. The lesson is compare yourself to who you were yesterday instead of who someone else is today. Look at your own QI and try to work on getting that better rather than comparing yourself to others. Because when you compare yourself to others, you're dealing with all kinds of confounders that may not show up. I'm going to go on to our transfusion vigilance. Transfusion vigilance, TRAN-O2, is a Aspire metric looking at the percentage of transfused cases with a post-operative transfusion, with a post-op hemoglobin of greater than 10 or greater than 30. You fail if that's the case. This only includes patients, I'll go into the inclusion metrics in a second, only patients who have gotten a transfusion up to 3 units. So if you've gotten more than 4 units, you're excluded from this metric. But if you've gotten 1, 2, or 3 units of cells in your case, and the first post-operative hemoglobin is greater than 10, we suspect that you've overtransfused. When we rolled this out at Yale, we had a lot of our ICU attendings, a couple of them get a little bit upset and say, why are you guys stuck on 10 grams per deciliter? Is that really what you're aiming for? Don't you know that 7's the ICU standard? I want to switch and talk about transfusion standards and how not to kill people using QI. And this is where the first do no harm, repeat as needed thing comes into play. In the New England Journal of 2014, there's a statement, it's time to adopt a transfusion threshold of 7 grams per deciliter as the standard of care. Well, let's see how that turns out. This is February 1999. Paul Hebert wrote this article. He's a big guy in transfusion vigilance. They did a comparison, a randomized study of 7 grams per deciliter versus 10 grams per deciliter in ICU patients, not in OR patients. Healthy and younger patients did better at a more conservative threshold of 7, and there was no difference in outcomes for older and cardiac patients. This is part of what led to the 2014 statement that 7 should be the new standard of care. Moving forward, this is 2011, also New England Journal. You'll notice I have a preference for quoting from them. This was a randomized trial of 8 grams per deciliter versus 10 grams per deciliter. Now we're getting closer to our neck of the woods if you're not an ICU person. This is for high-risk patients after hip surgery. This was after hip surgery, so it's post-operative patients. The FOCUS trial, patients specifically over 50 years old, do you transfuse at 8 or 10? No difference in outcomes. So maybe 10 is too high here. Why are we looking at 10? This is October 2014, lower versus higher hemoglobin threshold for transfusion and septic shock. We're back in the ICU, looking at 7 versus 9. This was in Copenhagen, so it's not just the Americans. No difference in outcomes between the two. So there was this kind of crescendoing move towards 7 grams per deciliter that came through in the 2014 statement I started with from New England Journal, that we should transfuse at 7, not a higher hemoglobin. In fact, just a little bit more on this is again Paul Hebert, the guy I mentioned before, back in 1999. He comes out with this grand statement: it's time to adopt a transfusion threshold of 7 as the standard of care. Though, to his credit, he also states that evidence still remains weak in patients with ACS. It may be proved that this distinct group of patients benefit from a higher hemoglobin concentration of 9 or 10. So there was a little bit of an asterisk in the recommendations. Well, let's go forward here. Now we're in 2015 and we're in the OR. Liberal or restrictive transfusion after cardiac surgery. This is the Titer 2 trial. I'll bet you $1, any of the residents, that that very few of the ICU attendings in your CT ICU will talk about this trial. Let's talk about why. They randomized patients to 7.5 grams per deciliter versus 9 grams per deciliter post-cardiac surgery. This was in the National Health Service, by the way. What did they find? Well, if you care about mortality, a restrictive strategy had over 60% relative increased hazard of death. 4.2% death in the restrictive strategy versus 2.6% death. It turns out that death was not the primary outcome. The primary outcome was morbidity and healthcare costs, and there was no difference in those two outcomes. The investigators, this is New England Journal, Titer 2, the investigators conclude, keep in mind, it took about 60-something patients in this group to the number needed to kill, which is a great evidence-based medicine metric. Number needed to kill was 62.5 patients. The investigators concluded a restrictive transfusion threshold after cardiac surgery was not superior to a liberal threshold with respect to morbidity and healthcare costs. They were, how shall I say, very rigorous. Very rigorous would be the favorable term. Their primary outcome measures were morbidity and healthcare costs. More people died, but it didn't make it into their conclusions because it wasn't their primary outcome. You can see in the supplemental appendix here, this is a Kaplan-Meier curve showing the dead people in red and the blue people, the dead people in the restrictive strategy in red and the dead people in the liberal strategy in blue. More people died in the restrictive strategy. As Mark Twain would say, they told a few stretchers. First do no harm, repeat as needed. You all know this story probably much better than the Titer 2 story, which for some reason has gotten buried a bit. The Nice Sugar story. Nice Sugar was patients in the ICU randomized to intensive blood pressure, intensive glycemic control, 81 to 108 milligrams per deciliter versus less than 180 milligrams per deciliter. Hypoglycemia less than 40 was 13 times higher in the intervention group. Again, this is 2009. Absolute risk of death increased by 2.6%. My favorite evidence-based medicine metric, the number needed to kill, was 38.5. You take 40 people and put them on intensive, and half of them, you take 40 people and put them on intensive glucose control. One of them is going to die who wouldn't have died otherwise. Here is a clinical takeaway that I love from critical care medicine. I'm just going to read it for you. Hypoglycemia seems to kill critically ill people, and tight glucose control under ideal circumstances in clinical trials is a likely iatrogenic cause of death. Keep blood glucose below 180 in critically ill patients with an insulin drip if necessary to avoid complications of both hyperglycemia and hypoglycemia. And finally, when evaluating any potentially harmful therapy as the new standard of care, beware of zealots with cool accents and stylish glasses. That was in pulmonary critical care medicine. I love it. There are a lot of dead people in the path of quality improvement, and we need to be careful not to increase that number. So we know we don't want to waste blood. This is a picture from the Sistine Chapel. This is Noah and the flood. You can see the waters coming in the back here is his rendering of Noah's Ark, and people are just dying left and right. And in this very bloody, probably the most bloody scene in all of Western literature, if you think about it, there's this statement in that section of the Bible: "Whoever spills a man's blood, by man shall his blood be shed." And it's just an interesting moment when you're thinking about conserving blood. Whose blood are you spilling and whose blood are you saving? So when you get your Aspire email and you see Trans 02 as one of the metrics, you should think very hard about who the exclusions are and how you are not causing bloodshed by trying to save blood. I think Aspire has done an outstanding job in trying to prevent blood loss in their prevention of blood loss. And here is how they have done that. First of all, they only include patients receiving red blood cell transfusions. Obviously, if your patient came in with a crit of 41, you didn't overtransfuse them. Okay, that's the easy thing. Exclusions: patients less than 2 years old, patients less than 12 doing cardiac, patients less than 12 with more than 30 cc's per kilo of red cell transfusions. ASA 5 and 6, they're gone. We're taking them out. EBLs greater than 2 liters, they're out. 4 or more units of cells transfused, they're out. If you're in an OR and you've gotten to 4 units of cells, the patient's bleeding, you're doing your best, they're out. We're not looking at your transfusion metric. Obstetric non-operative, they're out. C-sections with EBLs greater than 1,500, they're out. C-sections with instability or questions of instability in the hemodynamics, they're out. All postpartum hemorrhages, they're out. Take all of those cases away. Then look at the patients who were not in that category, who got 1, 2, or 3 units of cells. Did those patients have a hemoglobin over 10 within 18 hours post-surgery? Or, I'm sorry, did they have that and they failed? Or they could also pass if their intra-op hemoglobin was less than 8 when the decision was made to transfuse. And finally, even within all that, the threshold for success, 90%. We really don't want to cause blood loss here when we're trying to prevent blood loss. If you did it 90% of the time, you probably are doing this metric pretty darn well. And when you didn't, you did your best. This is the kind of humility that I really like about how MPOG comes to these metrics emphasizing. Having said that, Yale stunk at this metric. Here are some data on our first postoperative hematocrit in one of our participating hospitals among patients who were in this transfusion 02 metric and failed. The mean was 32.7 crit, interquartile range was 31 to 35. 25% of our failed patients at this hospital had a first post-op crit greater than 35. Again, this is only patients, excluding all that list, who got 1, 2, or 3 units of cells. Exclude them all, and still, the 1, 2, or 3 unit people were coming out with crits greater than 35, 1/4 of the time. Just to put a finer point on it, at this same institution at Yale, when we went to the blood bank and said, how many units are you guys giving out? The entire hospital, which happens to be a level 2 trauma center, so they're not getting the enormous traumas, but they're getting some pretty big traumas. They're getting all kinds of cases other than transplant. Their entire blood volume of their entire blood bank, of all of those cells, 1 out of every 5 units was going to the ORs at that institution into a patient who failed transfusion 02. So again, all the exclusions taken out, even the folks left behind, 1 in 5 was going to them. So this is a problem. Do our providers stink? Well, actually, no. We look at them and we say, okay, we have a problem here, but can we fix it? It turns out we didn't have point of care hemoglobin testing at this outlier hospital. There was one iStat machine, it was in the vascular room and it was locked after 4 p.m. These people did a ton of big spine cases going late into the evening, and they didn't want their big spines, which were slowly dripping blood, to end up with hemoglobins of 20. So they were doing their best. It's an interesting case of finding a gap in care and making sure not to ascribe that gap in care to a deficiency in the knowledge or effort of the provider. There was a systems issue that we identified and we made it better. In that process, there were a lot of opportunities for us to either kill people from under-transfusing or blame people who weren't at fault. And I say this story to you guys as a cautionary tale, both as an opportunity for you to improve your quality, but at the same time, be very careful. Be very careful. There are a lot of ways you can do this in a wrong way. This is our head of our blood bank, by the way, Yale, Ed Snyder. He's so well fun. He's like the blood in National Heart, Lung, and Blood Institute. He looked at our data, and I have to tell you, just to kind of contextualize this, this is kind of his reaction. You know, he was smiling. He said, you know what, 10 years ago, this whole curve would have been shifted to the right and the mean would have been 40. So it's fun to see kind of the older generation look at our current data and just kind of put an additional level of humility on it. We're doing our best and things change over time, and there are opportunities to get better, but you don't necessarily have to feel bad about yourself. Here's more of our transfusion vigilance stuff. We kind of trailed behind originally. Now we're kind of up around the mean. After we started giving out our emails, this is our % of failed transfusion O2 metric each month. And you can see in 2018 and 2019, our variability of failure went down, even if our failure was still below the 90% where we wanted it. We weren't all over the map like we had been before. So we reduced variability, which in itself can have some value. And this is just some data on how we've improved. The campus that I said was really lacking went from 66% pass rate. They jumped by 10%. And York Street campus, our main campus, went up to 91%. So we did have significant improvement, and I don't think we killed anyone in the process. All right, so I am just going to end here with some future directions. There are opportunities for you guys to get some money. This is the minutes we've charted between anesthesia start and room in 36,000 cases. We charge by the minute in anesthesia. You can see as we go through the day, I'll go through this quickly, our transport times to the OR, as we chart them, get shorter and shorter during the day as though we're getting sloppier with our transport time documentation. One of our MBA student, Yale medical students, took on a project to simulate how much money we're losing at Yale based on these minutes of time. We lose an average of about $484,000 a year in lost revenue because we're not charting properly. We're working on that. And it's just a lesson for you guys. There are a lot of little hidden pearls in these data that can actually bring you revenue. And here's another one that can bring you revenue and also help the planet. This is Sustainability 01, a metric by a couple of our environmentalist colleagues here at Yale, looking at the mean fresh gas flow in your cases. Was it less than or equal to 3 liters per minute? Unless you have nitric oxide going, there's extraordinarily few reasons why your fresh gas flows should be more than 2 liters per minute. We made it easy and said, all right, 3 liters per minute. And we still kind of stink at this. You know, 3 in 10 of our cases have a fresh gas flow greater than 3 liters per minute. We are just burning money, and we're burning the environment too, because these are all greenhouse gases. So those are the future metrics that we're looking at improving. So I'll just conclude here. I think MPOG and Aspire are useful for QI, they're useful for MOCA, they're useful for operational efficiency, they're useful for research. We have 15 investigators who have research projects. We've had funded stuff. The second thing is QI is dangerous. First, do no harm. The third lesson is data validation is an ongoing task. You should please complain to your local PI, and this is selfish. If your local PI does a better job, then the research we're doing on MPOG gets better. And then the final thing is that Yale's QI data have shown some sustained progress in a few things and some places where we can improve going forward. I'm going to stop there. And thank you so much for your attention this morning. And this is a thank you to the Michigan folks who have helped us get this going.
Yeah, I guess we can thank Michigan. Yeah, that's fair enough. Thanks, Rob. That was an excellent talk. You actually did have quite a few people on this call, but we hit the 7:30 mark and people are trying to get to the operating rooms to start their cases.
Oh gosh.
But that's okay. But it's okay. It's okay. I just wanted to let you go. But I wanted to make sure we have a lot of our QI people actually still on this call. And I wanted to see if anybody first has a question. Of course,
well, I don't necessarily. My name's Kathy Lauer. I'm the vice chair for quality, and we are we've been struggling through a lot of IT hurdles to get us to MPOG, and we finally have gotten there. So from your perspective, were you there when you guys first started, and what was there? Did you have to overcome a lot of I don't know, anxiety, stress over people starting to get their own Aspire data? And what would be some of the tactics that potentially you guys use just to reassure people that this is not punitive, that this will be used for overall, quality improvement?
Yeah. So first question, 2014, Roberta Hines pulled me into her office and says, "We want to do this. Go join." Well, maybe it was actually, that was probably 2012 when she first came up with it. So yeah, I was there at the beginning. And then we actually joined at 2014. And those 2 years were filled with this kind of anxiety, stress, and running into various IT walls. And it sounds like you guys have gotten through those walls. So congratulations, that's extraordinary. And it's not easy. And so, but you've done that. And so that's great. If you don't have access to Galaxy, which is Epic's kind of communal guideline for users who look under the hood, you should get a Galaxy password and go in there and look in the MPOG section. And there's a whole kind of cookbook of how to join MPOG, and it may have some useful stuff for you, kind of helping your IT people to figure out where the little bumps in the road are going to be. That's one thing. Second thing is provider relationships and preparing them. I think that if you come to it with an ethos that you're looking at EHR metrics that are imperfect, that this is largely informational purposes, and that you have maybe a few easy wins at the beginning that people can get on board with, then hopefully you'll get there. But I guess that's kind of it takes a lot of finesse and a lot of kind of gentle, humble kind of approaching folks, suggesting that, maybe 1 out of every 5 units of cells shouldn't be going to these patients with a crit of 35, and like really just trying to get like the low hanging fruit. And then, and then listen, like you listen. So yeah, well, that's great, but I can't measure my hemoglobin. Oh, really? It was an exercise. The exercises in humility are repeated and often. I remember hearing that they didn't have hemoglobin testing at this outlier hospital. And I just had to stop and say, whoa, like, hold on, like, thank you. The problem I thought we were fixing was the wrong problem. And so when you think you see a problem, I would say go talk to the people who are connected to that problem and make sure the problem you think you have is the problem you actually have. And if you go in with that questioning attitude and not the accusatory stance, you will both learn and also gain in the political capital that you earned with those people.
Great. I was actually thinking the same thing. I guess I don't think I really had a really good understanding what the Aspire part was. So thanks for explaining all that. And then I did get a little nervous. I thought, oh, am I going to be getting reports about, my performance? And so I like how you said, compare yourself to yourself. It's like, oh, okay. But it's going to be hard not to. That is a little anxiety provoking, but
the other thing we did early on is we told everybody, no one's going to know how you did as an individual. We will only look at our departmental metrics. And I would encourage that. So we actually have a couple of metrics that our hospital jumped onto, and they add them to the departmental incentive payments on their quality metrics. So folks who are in the OR a lot, I'm a once a weeker, so I don't even qualify. But a lot of folks get a little bit extra in their paycheck if the department does well on certain quality metrics.
Sure.
And we made sure it was as a department, because we did not want people either, penalized by case mix or feeling persecuted, and that we wanted to, inspire a team orientation. But you're always going to have that discomfort. It is hard. It's like, yeah, you see that. And the other thing I don't like is that these things are often articulated as percent failed. Failed isn't my chosen term, but that's the term that the consortium decided to use. So.
Okay. Any other questions for Dr. Schonberger? I know we're we are out of time, but I just want to make sure. Okay. Thank you so much, Rob. This was a wonderful talk, and hopefully it's going to get, it's kind of like the springboard for everyone getting excited about MPOG here, and we'll see where it takes us.
Thank you for having me. Happy to talk offline with anyone. And if you have any of your academic folks who are looking at K awards and stuff like that, happy to chat with them, because I think that's a key award. As you know, it's really a generous award and so key to be able to get it. And that's where I got the informatics training, which then led to this stuff. So
exactly. All right. Well, thank you so much, Rob. Have a great day.
Okay, you too.
All right. Bye-bye.